Ken Landau. Thanks for watching. Let's talk about the Restless Leg Syndrome, or RLS. It's also called the Willis-Ekbom disease. It's an urge to move your legs. It's associated with some kind of discomfort or peculiar feeling in the legs. We call it dysesthesias. This is a common neurologic condition that affects somewhere between 2 and 4% of the general population, with 1 in 10 of those people affected having such severe symptoms that it warrants some kind of medical intervention. The age of onset of the condition, typically between the ages of 30 and 50, but it seems that it affects 2 distinct groups of people. One over age 45, some under age 45. If they're under age 45, typically with a family history, can even occur in children. Women are twice as frequently affected as men if the women have given birth. Among women who haven't given birth, the sex incidence is equal. Seems to be more common in whites than blacks, more common in blacks than in Asians. The concept of the condition traditionally is that we have a primary condition under age 45, typically between the ages of 20 and 40, with the family history and a slow evolution of the disease. The secondary condition occurs in people over age 45. Arguably, it progresses somewhat more rapidly. There's comorbid medical disease that's present, and it may be familial even in the people over age 45, which brings up the idea that maybe there isn't really some underlying difference between under age 45, over age 45. Now, it's classified by some as a neurologic disorder, by some as a sleep disorder, but the essential diagnostic criteria are from expert consensus panels. And what they say is that the symptoms and the manifestations of the condition are expressed during relaxed wakefulness. So in the evening hours, typically, or even when you get into bed. Have different groups of experts. So we have these consensus panels. The International RLS Study Group is one. The American Association of Sleep Medicine is another. And typically, the American Psychiatric Association got into the picture. They came up with the DSM-5, Diagnostic and Statistical Manual, the 5th edition. But they don't even distinguish between intermittent and chronic persistent RLS. So we can forget about the American Psychiatric Association, and let's stick with just the RLS and the American Association of Sleep Medicine. So the definition: it's an urge to move the legs while you're at rest, mostly in the evening, of course, and that can lead to sleep disturbances because you can't get into a comfortable enough position to fall asleep. You often have the symptoms for somewhere between maybe 10 and 20 years before the diagnosis. And we talked about the secondary conditions because there's some other kind of medical condition that might be present. The evidence is relatively weak, except maybe for iron deficiency or iron deficiency anemia, where the ferritin, that's the level of the amount of iron that's in your system, the stores of the iron that are in your system, if the ferritin is less than 50, then a person might have an iron-related deficit as the cause. And as a matter of fact, it's relatively more frequent in those people who donate blood on a regular basis. But there are some tenuous associations, not really firm associations, with either a low folate or a low B12 or low magnesium levels, maybe diabetes or kidney insufficiency or Lyme disease or rheumatoid arthritis or hemodialysis. Actually, if we look at women who are pregnant in the 3rd trimester, somewhere between about 25 and 40% can develop the restless leg syndrome. Usually it occurs during the latter part of pregnancy and usually resolves about a month after delivery. But women who have the RLS during pregnancy are about 4 times at increased risk, 4 times greater risk, of developing chronic RLS. And we also know that about half of the people with RLS have attention deficit hyperactivity disorder, and about a quarter of the people with ADHD have RLS. Well, it's also associated with fibromyalgia and anxiety and depression, associated with insomnia and chronic neurologic disease, and even with Parkinson's disease. The Parkinson's disease might share some sort of underlying similar cause. Maybe it's activation of the sympathetic nervous system or oxidative stress or some kind of a metabolic factor. And as a matter of fact, in Parkinson's disease patients who are treated with the standard kind of medicines for Parkinson's, the dopaminergic drugs, levodopa and drugs like that, well, those people seem to be at increased risk for developing the RLS. But the RLS itself is not a risk factor for development of Parkinson's disease. But maybe both share some sort of sleep abnormality that might somehow be related to both. And controversially, there might be some sort of an association with either a heart attack or a stroke. Certainly, some medicines might increase the risk. The medicines like the calcium blockers or sometimes the antidepressants, typically the SSRIs, drugs like Prozac and Paxil and Lexapro, and the tricyclic antidepressants like amitriptyline. But interestingly, there might be a decreased incidence with an antidepressant like Wellbutrin, or a higher incidence with an antidepressant like Effexor. As a matter of fact, in the people who are taking Effexor, some reports suggest that the incidence of RLS might be as high as 30%. And as a matter of fact, an associated condition known as the periodic leg movements of sleep might occur in 75% of the people taking the Effexor, at least according to some reports. Now, also associated with antihistamines or the opioids or lithium, maybe even the beta blockers, and sometimes withdrawal from benzodiazepines, Xanax, drugs like that, or alcohol, or even the opioids. And there's a role of hypoxia, low levels of oxygen in the circulation. That might somehow be associated because we find that it seems to be higher incidence of RLS in people who have the obstructive sleep apnea or COPD, chronic obstructive lung disease. We can find there some histologic abnormalities present in the muscles and in the tissue of the leg especially that suggest low levels of oxygen. The condition itself can either be a mild nuisance, can be extremely debilitating. It can occur daily or it can occur only occasionally. American Psychiatric Association says in order to make the diagnosis of restless leg syndrome, it has to occur at least 3 times a week for at least 3 months. It can be intermittent, less than weekly to multiple times a day, can have significant variation from day to day, and it can be chronic and last for years. The symptoms, like I say, can vary in severity. Well, you have basically an underlying uncomfortable desire to move your legs. That's what the condition is all about. It's an unpleasant sensation in the legs, but it's hard to describe. It's an unusual sensation, not a typical sensation. It's not really painful, but it's really bothersome. Some people say that it's a burning or an aching or a tingling or a crawling or a tension or a prickliness of this underneath the surface. Some people say it's creepy or throbbing. People who have the condition can't sit quietly for long periods of time. They can't sit in the car, they can't sit in the airplane for long periods, especially in the evening. The symptoms begin when they're relaxing, when they're reading or studying or trying to sleep. They have an immediate restlessness, an intense anxiety if they don't move. Some of the people think that they're suffering from arthritis. But the movement brings either complete or partial relief. So by walking or bicycling or other sort of physical activity where the legs are moved up and down relatively rapidly toward each other and away from each other. Now, each individual may have a unique movement that seems to be associated with resolution of the symptoms. The symptoms occur, these pins and needles sensations, occur mostly below the knee, mostly in the calf and the back part of the leg. Usually the symptoms are deep. They're close to the bone or they're deep in the muscle. They're not near the skin. They tend to be bilateral in most cases. It's only rare that it's purely one-sided. Movement tends to bring relief. Again, it's worse in the evening or the night. Symptoms may resolve in the early hours of the morning. So in other words, even though you might have difficulty getting to sleep, the legs seem to move around. Well, after about 2 o'clock, 3 o'clock, 4 o'clock in the morning, symptoms seem to go away. Now, if we look at the people who are less than age 45, they have the slow onset, the condition can disappear for several months, even to several years, then it progresses and worsens as you get older. It's misdiagnosed in children as growing pains, according to the RLS Foundation, the Restless Leg Sleep Foundation, about a little less than half of the cases have the first symptoms that occur prior to age 20. Among those people over age 45, the onset tends to be relatively sudden. It doesn't tend to worsen. You can have the daily appearance right from the onset, usually associated with a specific medical condition. That's why it's called a secondary problem. It has the circadian pattern where the symptoms for some reason are worse in the evening. Some of the people have symptoms only when they get into bed. Others have them throughout the evening hours. Sometimes, and rarely, they can even persist into the morning. Severity obviously varies quite considerably. About 90% of the people with restless leg syndrome have difficulty falling asleep, staying asleep, or have poor quality of sleep, and that can lead to other kinds of problems like being late to work or missing events due to drowsiness or even driving while they're drowsy. And there's another condition that frequently overlaps and frequently is confused with restless leg syndrome, and it's called the periodic leg movement of sleep. It's kicking movements. And these kicking movements were originally thought to be part of RLS, but they're really a condition that occurs while you're asleep. They're repetitive movements, involuntary movements that last anywhere between half a second and 10 seconds. They can occur quite frequently. They can occur 10 to 15 times an hour, sometimes even as many as 60 times an hour. They can be associated with an increased autonomic nervous system that pushes up your blood pressure, pushes up your heart rate, and as a result, sometimes these people in the morning, they complain of a headache, either a migraine type or a tension type. It's associated with bringing back the foot toward the front of the knee, and then bending of the ankle, bending of the knee, bending of the hip. The legs don't necessarily move synchronously or symmetrically. And 80% of the people or more have the restless leg syndrome. Now, some of the people who have the periodic leg movement of sleep disorder, they can have it if they're otherwise healthy, or they might have other associated sleep abnormalities. Some of the symptoms of restless leg syndrome, excessive daytime sleepiness, sleep disturbances because of itself, because of the RLS, or because of the periodic leg movement of sleep that frequently is associated with it. And the periodic leg movement of sleep, remember, typically occurs while the person is asleep. The restless leg syndrome typically occurs while the person's awake. So how do we assess it? Well, there are different kinds of rating scales. The International RLS Society has a rating scale. The Edmonton Symptom Assessment System has another rating scale. The evaluation is really basically just a questionnaire. Say, do you have trouble falling asleep because you have an urge to move your legs? Do you wake up at night because you feel your legs need to move? Do you have some sort of peculiar feeling in your legs when you lie down and go to sleep? Do you feel better when you get up and move about, stretch your legs? Those are the way we make the diagnosis. Generally, there's no need for any further medical study. You don't have to do sleep studies, don't have to do any nerve conduction studies, but you do have to differentiate the condition from several other problems. So, for instance, some people get nocturnal leg cramps. They're painful, but they're usually one-sided, associated with muscle hardening. Some people have peripheral neuropathy that makes them want to move about. Have to differentiate it from diabetic neuropathy, other types of neuropathy, or peripheral vascular disease. We have a condition known as akathisia or restlessness. It's not correlated with rest. That occurs all day long. There's no circadian variation. Sometimes it's just positional discomfort. You're sitting on your leg, you're sitting on your foot, and it tends to, as we say in the trait, fall asleep. Or sometimes people have a habitual foot tapping or leg rocking condition. Well, there's a strong genetic component to the condition. Seems that somewhere between 1/4 and 3/4 of the people who have the condition have some sort of underlying genetic issue. It can be passed on through a number of complicated patterns, not only just the autosomal dominant, autosomal recessive. And interestingly enough, a genome-wide association study found about 19 different loci associated with the RLS. And interestingly, none of them had anything to do with either the dopamine system or the brain iron system. Well, it seems that as far as brain development is concerned, that neurodevelopmental abnormalities might explain some part of the condition. So it might have to do with neurogenesis, the development of the nerves, or the guidance of the axon to where they're supposed to go, or even the synapses that occur. Now, pathologically, it seems that the condition involves some of the neurotransmitters, some of the chemicals in the brain that tell one part to tell another part what it's supposed to do. And it seems like the serotonin and the norepinephrine and dopamine are somehow involved. And it seems the receptors for those areas might be involved. And it seems that the brain iron, well, that might actually cause a deficiency when the brain iron is low of a chemical known as adenosine. And the adenosine somehow is involved in these receptors in the dopamine. Well, now we've made the diagnosis relatively simply. And the question is, how do we treat the condition? Well, the goals of the treatment, first of all, are to increase the person's quality of life, of course, decrease the symptoms, improve the sleep quality, and to decrease the daytime sleepiness. So the most important thing is to optimize your health. So evaluate for any other kind of medical disease that might be present or might be associated with it. Consider things like meditation or hot baths or cold baths or whirlpools or limb massages or vibration of the legs or electrical stimulation or yoga or maybe acupuncture or some kind of physical therapy, lifestyle changes. Want to exercise regularly, maybe some aerobic training, resistance training. But if you exercise excessively, that can actually make things worse. We know for general hygiene, we always recommend stopping cigarettes and don't drink too much, don't have too much caffeine, sometimes a massage of the leg or distraction. There's mental alertness that can occur during the night that can distract you. So you can do crossword puzzles, or you can knit, or video games, or iron. And for some people, a sleeping pill might be relatively good. Now, when we talked about iron, it seems that iron can somehow be involved in the dopamine pathways. And it's very important to realize that the iron that you have in your system, when we draw your blood and analyze the iron level, well, that's not really correlated with the amount of iron that happens to be in your brain. And the amount of iron that's in your brain is important for the manufacture of the dopamine. And it's important for oxygen inside the brain. So there's no real approval for iron. The FDA hasn't said that iron's an approved therapy, but iron is available readily. Now, most people take iron orally. Rarely they use it intravenously. If the ferritin level, a measure of the iron, is over 50, unfortunately, the iron isn't going to get into the system very much, certainly not going to get into the brain. Well, if we want to push the ferritin, which is thought to be appropriate, to more than 100 in people who have the restless leg syndrome, pretty much you have to use the intravenous iron. But intravenous iron, again, is not an FDA-approved indication. The RLS is not an approved indication. So we always have to consider, well, depending on what type of iron is used, sometimes people get anaphylactic reactions, horrible reactions to the iron. So that's one kind of avenue that can be pursued. But you have to realize that placebo therapy causes large improvement in the RLS symptoms, causes moderate improvement in the quality of life, but only causes minimal improvement in the quality of sleep. So in 1982, levodopa was introduced. That's what we call a dopamine agonist. And it seems that you can take this drug on demand. Intermittently you take it. And it can help you if you take it at bedtime or when you wake up in the middle of the night. But unfortunately, if you take it at the first part of the night, when you go to bed, it might improve the symptoms, might get you to sleep, but unfortunately may cause, very frequently causes, 20, 30, 40% of the people can have a rebound in the second half of the night. So then we could use a controlled release form of levodopa, carbidopa, levodopa. And if we use that, then it can help throughout the night. Now, if you take this medicine, you don't take it with high-protein foods. But then some other medicines were introduced, and they could be used just at night. You could ignore the daytime symptoms. And these drugs, known as dopaminergic agonists, they came on the market about 10, 15 years ago. The European Medicines Agency, the Food and Drug Administration, approved them. They had already been on the market for Parkinson's disease, but now they were approved for treatment of the RLS. These are drugs like Requip, which is ropinirole. That came out in 2005 for RLS. Then there's Mirapex, came out in 2006, and Nupro came out in 2007. Well, these medicines seem to have something to do with the dopamine in the brain, and seems like the drugs are effective for anywhere between about 2 and 12 hours. And if we talk about the Nupro, that's a transdermal application. It can improve both the daytime and the nighttime symptoms. Of all of the drugs, only Requip seems to be associated with improvement of RLS if we look in the sleep laboratory, in the sleep tests. Well, the medicines do have some side effects, and the side effects include nausea or somnolence, or sometimes people's blood pressure falls down quite low when they stand up and cause some lightheadedness or dizziness, cause them even to fall. And these drugs are associated with impulse control disorders, so uncharacteristic gambling or spending or hypersexuality or shoplifting. Well, unfortunately, both of these approaches, either with the levodopa or the dopamine agonists, they can induce something called augmentation. And augmentation wasn't recognized initially because most of the studies that were performed on the drugs, the Mirapex and the Requip and the Nupro, they were short order. They lasted less than 12 weeks. Relatively few trials lasted more than 6 months or up to 4 years. And that's why augmentation, it's a late onset condition. That's why it wasn't really found. So augmentation was first noted in about 1996. It's iatrogenic. It's caused by taking the medicines. Some people can develop more severe forms of this RLS. It's known as intensification of the symptoms. Or you could develop the manifestations of the condition earlier in the day. Instead of just at night while you're trying to fall asleep, it could come on at noontime or even earlier. It's not the natural progression of the disorder. It's not that the drugs don't sufficiently control the nighttime symptoms. It's just that a person has worsening of the condition. So anybody who's been taking the drugs for more than 6 months who has worsening of the symptoms or needs an increased dose probably is going to be suffering from this condition that we call augmentation. So as a result, you should take the lowest dose possible for the shortest period of time. Now, some people suggest that even the appearance of daytime symptoms, breakthrough symptoms, those are the first sign of augmentation. And augmentation can spread not just into the legs, but also into the arms. And we find that oftentimes people who have augmentation have a history that they haven't told the doctor that the symptoms are getting a little worse, so they start taking increased dose. So if we look at augmentation itself, it's going to occur with these medicines at the rate of about 3 to 9% per year. If we look at the Mirapex, in 2 years, as many as 30% of people may have this augmentation. And over a 10-year period, up to 70% can suffer the symptoms. Now, the Nupro is associated with a lower order, but even after 5 years, about 1 person in 8 is going to suffer from this augmentation. And it's interesting that about 75% of the people who have restless leg syndrome, who are referred to national experts because of their terrible RLS, well, what they're really suffering from is this augmentation, the complication of the medical therapy. So when we're evaluating people, we want to make certain that what we're calling augmentation isn't just the end of the dose rebound, or with the rebound, it's not going to spread to the arms. We want to make sure it's not tolerance because you're tolerant of the medicine or natural progression of the disease or some other kind of a factor that might have developed. But the question is, how do we treat augmentation? Well, we have to withdraw the medicines for the most part, withdraw those dopamine agonists and the levodopa. And that means that the person can have really severe symptoms for somewhere between 1 and 4 weeks, typically 10 to 12 days. They're going to have dramatic worsening of the RLS, going to have round-the-clock symptoms. Possibly they're not going to be able to sleep. How are we going to treat it? Well, we correct the iron level if we can. There's a certain type of gabapentin that can be used. It's called Horizon. Sometimes in some countries, not in the United States so much, but in Europe, they use low-dose opioids combined with naloxone. Or we can use the Nupro patch because it's 24 hours, and that seems to help some people, as long as that wasn't the cause. Now, because of the complications of the medicines that I've been talking about, the dopamine agonists and the levodopa, well, it seems that we're now turning to types of what we call the alpha-2 ligands, and this means gabapentin and acrobyl. The trade name for that is Horizon. It's a prodrug. It breaks down into gabapentin. It's slowly absorbed throughout the entire gastrointestinal system. It's the only approved drug for the treatment of RLS in the gabapentin family. The gabapentin itself is a pill, of course. It's poorly absorbed. You have to take it several times a day. It can lead to augmentation, but much less likely. Lyrica can be used. Gabapentin is used at a dose of somewhere typically between 700, 800 milligrams, start off at 100 to 300 milligrams, a couple hours before you go to bed. It can cause some unsteadiness of the gait and somnolence. The Lyrica is used at a lower dose, maybe about 75 milligrams to start, increased up to a standard of anywhere between 150 and 450 milligrams. The Horizon, the gabapentin and acrobyl, well, that's quite expensive. No generic is available, but it is FDA approved. A dose of 600 to 1,200 milligrams at night. You take it around 5 o'clock. So now we have the guidelines, the current guidelines, that used to suggest the dopamine agonists, those drugs like Mirapex and Requip, Nupro. Now they say, no, we prefer you take the gabapentins. You take them when necessary. You take them an hour, 2 hours before you go to sleep or before the anticipated onset of the symptoms. If the symptoms tend to occur around 8 o'clock at night, well, then take the medicines around 7 o'clock at night. And if you have just mild or intermittent symptoms, well, then you might not need any kind of therapy, except perhaps if you're going to have a period of limited opportunity for mobility. Maybe you're going to be sitting in an airplane seat for 6 hours or overnight. And if that's the case, then maybe it's appropriate to take some medicine. So the guidelines suggest if you have daily or if you have moderate to severe symptoms that interfere with your sleep or alter your daytime function, then it's appropriate to use some kind of therapy. Now, there are other kinds of therapies too. Some experts, like I say, suggest the oxycodone-naloxone combination. It's prolonged, low release, slow release. It's not available in the United States. Benefit from that is there's no augmentation. In the old days, we used to use the benzodiazepine, specifically clonazepam, Klonopin. That seemed to be pretty good. It has long duration of activity, seems to not be associated with a significant number of side effects when it's taken just intermittently. Unfortunately, it's one of those kind of drugs. It's in the benzodiazepine class, and that's sort of falling out of favor at the present time. Certainly, if a woman is pregnant, we like not to use any drug therapy. Treat with iron supplements if that's appropriate. Consider other forms of therapy, but try to stay off the drugs. Interesting, there seems to be some sort of a link with depression. It seems those people who have depression have a higher incidence of restless leg syndrome, and the treatment for depression seems to be associated with a higher incidence of restless leg syndrome. So it's a catch-22. But it seems that some of the medicines used for treatment of depression can be helpful. So remember we talked about the Wellbutrin. Some people say trazodone. Unfortunately, some people say some of the antipsychotics, but the antipsychotics have a whole lot of other symptoms that we would like not to suffer. the dropout rate of therapy, if you're taking some of the medicines for restless leg syndrome, is as high as 25%. Previously, other medicines were used, cabergoline or clonidine or amantadine. Sometimes people even use valproic acid or depakine or valerian, but there's no adequate evidence that they're any good. Now, it has an interesting history. Actually, Sir Thomas Willis in 1672, he first described the condition. The manuscript was originally in Latin. It wasn't translated into English for about 10 years, 1685. Then there were multiple subsequent descriptions, but nobody paid any attention to the condition. In 1945, Dr. Ekbom, he detailed the condition in his doctoral thesis. He actually coined the name. And then the condition was largely ignored into the 1980s. But now the condition is widely recognized. And as a matter of fact, the Restless Leg Syndrome Foundation, they renamed themselves the Willis-Ekbom Disease Foundation because they wanted to eliminate the incorrect description, because it could be in the arms too. And there also was a trivialization, a lot of humorous treatment in the media because of the restless legs and what the meaning of that could be. And then they also wanted to pay tribute to Dr. Willis and Dr. Ekbom. So basically, there you have it. We have a condition that's very common. It's poorly understood. It's feeling that you have to move your legs. It occurs during the late evening hours or at bedtime. And it seems like the constant movement of your legs interferes with your ability to sleep. And in many cases, it's associated with this other condition that we call the periodic leg movement of sleep, PLMS. Treatment is only when absolutely necessary, since the traditional therapy is now not really well thought of and causes a significant number of side effects. So I'd suggest that you undertake all of the other kind of non-medical issues prior to your taking any kind of pills. And if you do take the pills, if you do take the medicines, you have to be alert for the onset of side effects, because especially if you choose the Mirapex or the Requip or the Nupro, you can have some major problems. You can have this augmentation. You can have significant worsening of the syndrome, and it can spread to your arms, and it can interfere even worse with your sleep. And in the old days, it used to be a low dose of some of the benzodiazepine, especially a drug like Klonopin, seemed to be very helpful, but now we tend to frown upon that, but it seemed to be helpful. So whatever you do, be careful. You don't want to have the treatment actually cause more complications than the disease. Anyway, thanks for watching. If you enjoyed the show, please tell a friend. Consider subscribing so you'll get updates as soon as we post new videos. I appreciate your interest. I'm Dr. Ken Landau.